Okay, so we're gonna make good use of the time that we have together today, and we'll get started. I'm Jenny Bencardino, Vice Chair of Faculty Affairs at Montefiore Einstein, and I have the pleasure to moderate today's session on paid family leave, redesigning the radiology workplace of the future. And this is sponsored by the Committee of Diversity, Equity, and Inclusion of the New York State Radiological Society. So I want to give a little bit of a background on today's date. Today is December 11, and in 1946, UNICEF was founded. UNICEF has played a significant role in protecting the rights of children all around the world, and it was started after the war as a response to all the humanitarian crises that wars bring along. So in 2000, the International Labor Organization Convention came up with recommendation 183 that called for 14 weeks of leave for mothers of infants. And this was followed with recommendation 191 that brought up the number of weeks to 18. And many countries have implemented this recommendation. So we have here two tables and maps that show metrics of global availability of paid leave. On the left, maternal leave, and on the right, paternal leave. And you can see that in 1995, prior to the ILO recommendation, there were 21 countries still with no paid leave at that point. And fast forward 20 years to 2015, so this data is 2015 data, only 8 countries remain without paid leave. That's 4% in the world, and this is for mothers. For fathers, it's a little bit different. So we have 79% back in 1995 had no paid leave. And then that has been brought down to 48%. So we're making a lot of ways to improve the conditions of families all around the world. It is well known that having paid family leave brings well-being to children, particularly because mothers will have time to breastfeed, and that has been determined as something really important, particularly during the first 3 months of the infant's life. And then we also know that immunizations significantly affect the lives of children, and having a parent at home that can take children to immunizations also has a very significant impact in their health. It is now time for me to introduce our speakers. We have first Dr. Amanda Baker. She's assistant professor in radiology and neurosurgery at the Montefiore Medical Center and Albert Einstein College of Medicine. She's going to be followed by Dr. Elizabeth Kagan Arleo. She's a professor of radiology at New York-Presbyterian Hospital, Weill, Cornell Medicine, and she's the editor-in-chief of Clinical Imaging. And then we'll have Dr. Lori Deitte. She's professor and vice chair of education, vice chair for continuous professional development at the Department of Radiology and Radiological Sciences of Vanderbilt University Medical Center. So the webinar dynamics is that each of them has a topic. Dr. Baker is going to do the interventional radiology perspective. Dr. Arleo is going to talk about paid family medical leave in radiology, brief recap and next actions, and then Dr. Deitte is going to end with designing our future. We're going to be using the Q&A window. Please don't use the chat window. I left a welcome message there, and write your questions once the talks have been presented, addressing specifically one of the speakers. So I'm going to stop sharing my screen, and I will leave you with the first speaker, Dr. Baker.
Hi, thank you so much to Dr. Bencardino for inviting me. I'm going to share my screen. Okay, so my name is Amanda Baker. I am an assistant professor at Montefiore and dual trained in neuroradiology and neurointerventional radiology. And I love the title Redesigning the Radiology Workplace of the Future. I think we have a lot of room to go in redesigning some aspects of medicine. And I'd like to just start this webinar with a bit of a personal perspective. Traditionally, paid, although now it's parental leave, has been previously a female issue in maternity leave. And so to give some perspective as to why I was invited today, my path has been predominantly male. I think doing a diagnostic radiology training, which is still predominantly male, was the most percentage of female I've experienced in my schooling. And so that is just a little background. I'd also like to just share my sort of three major roles in life as a neurointerventionalist and neuroradiologist, but also a mom and a wife. And that I think normalizing the entire life for a physician may be helpful in our future goals for this aspect. And I have a 5-year-old who I had during radiology residency and a 2-year-old that I had during a neuro-IR fellowship right at the end. And so the reason I was invited to speak today and some of the perspective is that within neurointerventional radiology, there was absolutely nothing that existed when it came to pregnancy or parental leave. And so during my fellowship at UCSF, I decided to try to change that. And so I wanted to give some insight into my experience in doing so. So I created a position statement through the Society of Neurointerventional Surgery for this, based on my experience as a fellow and in listening to many females through our Women in Neurointervention group. We then did a podcast, and so there's a QR code for anyone who'd like to listen. And this ended up being picked up in a couple of articles by Neuro News, because this was really an interesting and sort of first time someone had approached this topic, given it's 90% male and not that many women are pregnant and along the way. And some personal motivation was that, obviously it was not easy. And I think, trying to pretend that it was is just doing a disservice to enacting change. And so one of my attendings at UCSF, really inspired me by just telling me, you have a lot of negative energy from some of your experiences. So, channel that energy into a positive outcome. And I think that's what happened. And just to also be the change, which is a Gandhi quote, but be the change. And I think that hopefully if there are, any trainees on this webinar, you can be inspired to change where you think. And so in terms of the specific leave policy, we wanted to make it fair but equal. And so the policy includes 6 weeks of leave for vaginal and non-birthing parents, as well as 8 weeks if there is a C-section. Address some radiation exposure during pregnancy according to some of the federal standards, and then touch on lightly family life in terms of breastfeeding, given the importance, as Dr. Bencardino described, and flexible vacation to allow for some of that to be used for leave. And it really didn't get into any of whether or not the leave would be paid, but just having a statement that stated that you can take leave as a parent was the first time. And we were inspired by other areas within medicine, as well as some federal and state laws. And so there have been many federal laws since, the Fair Labor Standards Act from 1938. A lot of these things will actually apply to pregnancy and to being able to take leave, in addition to the state regulations, and now increasingly so medical societies and ACGME. Every year there seems to be changes now, and more and more leniency for the issue of having a family, particularly in the era where the traditional family structure is not always what people are doing, and they also need leave, whether it's surrogacy or same-sex couples. And so everyone needs to be treated in a way to support having a family and a life outside of being a doctor. And then in terms of the specific specialties, and most have 12 weeks, but there are a lot of specialties that still only offer 6 weeks. And that is, I think, generally because of call, and it's very difficult for some of the surgical specialties who have less number of residents or people in the specialties. And so that is highlighted in the article as well as in this table. And so and one more thing I want to add here is that even the 6 weeks, it didn't get, it was a peer-reviewed article and it didn't get the best responses. And so I think we still have a ways to go in terms of some of the more experienced generations that have issue with people taking so much leave. And so where are we going? This is, part, I think, of an active recruitment of women to be able to break down some of these barriers for parental leave that may alter people's decisions in terms of what to do with their career. I think COVID taught us a lot about the workforce and being able to be more flexible with family life and work, being able to work from home, having more flexibility with child care and scheduling. And I think that it highlights a need for a balance of salary, promotion, research funding, and industry relationships, which are still markedly unbalanced, particularly in NeuroIR. And this has also helped us to understand some barriers of entry to some of these specialties. So in areas in which I have still found problems, and it's a first step to write a policy, but I look at it as just that, a very first baby step. And there's still a lot of areas in which we need to improve to make this policy the norm. And one of those things is to have women supporting women. I have noticed that sometimes it's harder for women than our male colleagues to actually say, I need this time and I'm going to take it without guilt. I personally, as a mom and a doctor, have guilt any day of whichever way I'm turning. I'm guilty about work or I'm guilty about my family. And it's really hard for women to let go of that guilt, but it is helpful to have female mentors and support in this way. The call schedules can be difficult, and so building in some flexibility into the an organizational level in terms of allowing locums or moonlighting to cover for people who are on paternal leave, and really accepting it for other colleagues to accept that that person is out for a long time and not make them feel bad about it. And while that sounds really simple, I think that that's human nature. It's really hard for people to actually accept this change of being able to let people not work in medicine. And part of that is because we really do, as doctors, have a diminished focus on our own health, our own need to breastfeed. I can't tell you how many people I hear talk about, oh, it's okay, just give formula, no problem. And sure, we all know that it typically is not a problem. However, there's a lot of data that suggests that breastfeeding is the healthiest thing to do. And, we don't even talk about the bonding that needs to happen, whether you're birthing, non-birthing, surrogate, all of these ways to have children now, you need that time, as well as recovery for the birthing parents. And so this would require financial and budgetary adjustment, which I don't think has happened or is very much in the conversation. And then in terms of childcare post-leave, it's insanely expensive and very difficult in this country. And so I think those areas are ways in which we can continue to improve. And when I look at the future, I hope these are some of the areas in which we have ways that I think people will touch on that we can change. And so what I learned in doing this is that all of the women who I have talked to who've come before me have their own stories. They've all seen, heard, and experienced innumerable things. And so these topics affect everyone, and they affect every industry. My friends in banking, tech, you name it, law, I think everyone is having this problem and these problems with leave. And so maybe there are things that we can learn from other industries. But the positive is that this is an evolving, ever-changing and dynamic situation that I do see is continuing to get better. So we are all not alone. And I would like to thank my personal mentors and everyone at Montefiore for helping me start this journey of change for radiology.
Thank you very much, Amanda. So we're going to continue with the program, and next is Dr. Kagan Arleo. Elizabeth, please take it on. You are muted.
Can you hear me? Now there's going to be an echo.
Maybe you have the presentation or the link open twice. Here. Yeah, your microphone is off.
I am happy to go next if that would be helpful.
Yeah, let's do that. And
Okay.
perhaps Elizabeth can go out and come back again. Okay, so let's move on to Dr. Deitte. Deitte.
Yes, it's okay. It's all good. It's all good. Let me just get my
I've been
presentation.
practicing all night and this morning. But
No, it's all good.
good.
Hi, I'm Lori Deitte, and I am from Vanderbilt, and I'm happy to be here and talk about. I'm going to be sharing some of my experiences, but also about how we look to the future. I've been very involved with the ACR, past member of the Board of Chancellors, and also past president for the Florida Radiology Society, and a current co-chair for the AAWR Advocacy Committee. So I'm going to start by just a brief glimpse at the past, and I'm going to start with my why for advocacy. And these are my three now grown children, all in their 30s. And our daughter, Amanda, here was born during my first year of residency during August. And there was no such thing as any of you that have had babies back then, like a parental leave wasn't even a term, I don't think. Maternity leave it was, but in medicine, we didn't really talk about that. So I basically used my 3 weeks of vacation and 2 weeks of sick leave. One was from my internship. I was able to combine it, and I had 5 weeks total off. And it just wasn't enough. It was really hard. But that was my first baby. Then I decided after that, because that was hard, that I'd wait 5 years. And I had the next one, and that's my son, Kevin. He was born at the end of my fellowship year. He was actually born on June 30th. So I timed it so it was very last day. And then I did take 10 weeks off, but that was it was unpaid. It was between ending my fellowship and starting my new job. So I had 10 weeks then. And then I started my new job, which was in private practice. I did that for 12 years. But at the end of the second year of private practice, I had our son, Scott. And then I took 8 weeks off, and that was a combination of vacation and sick leave. So that was my story. I will tell you, after having our daughter, Amanda, I already thinking to the future was, we need to change this. Like this needs to change. So I'm going to jump forward now. And for years, this is something I've been really interested in. And then the time just was right. I joined Vanderbilt in 2015. And and Lucy Spilluto and Stephanie Spotswood had just started the Women in Radiology program. It was one of the earlier ones in the country. And so right away, I was involved with that, and then also became a member of the ACR Committee for Women. And then Elizabeth Arleo, this is what really jump-started some of this. She approached me about advocacy efforts on family and medical leave, and would I be interested? I was the outgoing president for the Association for Program Directors in Radiology, so a lot of my work was with residents and trainees. And I said, yes, I would love to be interested. And so we did put together a statement. And then since then, I've been involved with multiple different fronts of this. In 2022, I did become a member of the AAWR Board of Directors and Advocacy Committee. And now I co-chair the Advocacy Committee. Just a few articles. Elizabeth will be showing you some other ones, but this one we're both showing. This was actually kind of a landmark article for us. But some of the other areas in 2021, we could already see from the trainee standpoint that there were going to be changes. And so we started to write about how do we ensure a smooth transition for trainees returning for parental leave, and how this call to action to ensure that trainees can have some time off during their residency training. And then the ACR passed Resolution 13, which was the paid family and medical leave. Many of us were at that meeting. It was exciting, but the wording is the ACR recommends that practices and departments strive to provide 12 weeks of paid family medical leave in a 12-month period. And that was passed by the council, which is actually more private practice. There's more private practice folks on the council than academic, but it was passed by the ACR. So now I want to move to the present. Where are we now? That was just a brief recap of where we've been. And the formation of the AAWR Advocacy Committee formed in 2023. And we had a couple charges related to paid family medical leave. One was to put together a resource webpage, and that link was shared with you for this webinar. But that went live in March 2024, and it includes a historic perspective, sort of, some of the policies that needed to be enacted along the way, links to resources, multiple FAQs, and there's links with those, and then a tab for comments and suggestions. Presently, we are socializing this webpage through posting with organizational websites, such as we partnered with the ACR, the APDR, the ASNR, and we're looking for other partners to help share this information. Social media, webinars, announcements, annual meetings. And this is what it looks like. And some of you may have seen this, but I would encourage you to explore it. Just click that link and take a look, because we do have, this is the summary of sort of the background, and then these are resources. Two of these resources were included with the webinar. But there's other resources, because some of this is state level. So there's policies, and then the FAQs. The other, and I want to highlight first, Kurti Magudia. She is the co-chair at the AAWR Advocacy Committee with me, and she helps spearhead a survey. The survey is, so the Advocacy Committee, AAWR, and then the ACR and SWRO all came together for this survey. It was deployed just this past July, and the ACR members were stratified as to who received it, because there's so many. So it was sent, so there'd be representative, different perspectives. And then AAWR and SWR members. And the duplicative responses were removed. Respondents came from a broad range of practices: academic, private practice, hospital-based, private equity-owned, VA, and others. And I'm going to share with you kind of the high-level points of the survey. So our takeaways. So number one, paid family medical leave is more common in academic and hospital-based practices compared to private practice right now. And it's also more common in larger practices. Number two, 1/3 of paid family medical leave requires the use of vacation or sick time. And I know I shared with you when I was a resident, like that was the only leave I got, was, whatever I could combine. But 1/3 of the leave policies require the use of vacation or sick time. Number three, I was actually a little encouraged. I'd like to see more, but 25% of respondents said that they had paid family medical leave of 11 weeks or greater, which is certainly, I mean, over the years is an improvement, and we'd like to see that go higher. And then number four, I think this is important. So 72% of the respondents, and this is all respondents, indicated that paid family medical leave is an important consideration when choosing to remain at or selecting a new position. So we're talking about retention and recruitment here. And this is important. And as we know, we're all facing workforce issues. So this is considered to be important by the people we're recruiting or trying to retain. I did want to just mention on the bottom here, there is a manuscript that's under preparation, and this will have a greater final survey results and analysis, and I look forward to seeing that come out. So the future. This is from the article. I'm going to summarize some of the points from the article, and Elizabeth Arleo and Kirti Magudia helped, and there's others I listed here, helped co-authored this article, but it's the practical guide for paid family medical leave in radiology. I'd encourage you to take a look at it, but a few points. One, we need policies. Like we checked with even residency programs, and there were a lot of programs that didn't have policies. There was a lot of variability in the policies. So we do need policies, and in our practices and our departments and in our programs. And at a minimum, these need to meet federal and state laws. It's also helpful to perform a cost-benefit analysis of the impact of leave, to identify what might be the barriers. And I know Amanda mentioned a few of the barriers. What might be the solutions? Can we plan to have locums moonlighting, other ways to help implement? And we have to be prepared for employees to take leave. It's not a question of will any employees take leave, or they will. Okay, they will. It's just a question of when. And sometimes it's planned. Sometimes it can be planned way in advance. And that's really helpful because then we can make the necessary adjustments to schedules and workloads. Sometimes emergencies happen. It can be medical emergencies. It can be family emergencies. And it's not, you can't really, it just happens. And then we need to have ways to accommodate it. Providing flexibility is important. And I think Amanda mentioned, we have home workstations. And so this can be helpful if somebody has medical issues that they can work, but they can still want to work intermittently. That would be an option. Maybe they could work from home. As long as they're not on FMLA. If you're on FMLA, you really can't work. And what about productivity metrics? Prorating RVU expectations for when you're on leave, or maybe pausing the promotion clock if that's what's desired by the person that's taking leave. I think here, one of the messages is that leadership is really important to ensure that all employees are aware of their leave allowances under any policy that's developed. This isn't just about women. I think that's so important and sometimes gets overlooked. And it's important when we're developing policies to consider all affected individuals and perspectives when we're developing the policy and to try and address that in the policy. So I'm going to be wrapping it up with why does this matter? And also from this paper, there's definitely known established benefits to individuals, families, organizations, departments. Recruitment, retention, super important, morale, and to society. It is becoming increasingly important in radiology. There's been policy updates and also in national and governing bodies. And our recent surveys results actually show 72% of people that we might be trying to retain or to recruit think this is important. So we need to think this is important too. And this is not just a women's issue. It's relevant to workers of all disciplines, all genders. Any one of us. I mean, if we asked even on here, how many have had to take some kind of leave? I'm not going to do it, but I would just say this can happen to any of us at any point during our life. Okay, my next slide doesn't seem to want to advance. Let me just try that again. There we go. So I'd like to end by inviting you to reflect. I know Elizabeth still has her talk, and when our talks are done, to reflect on our session as we redesign the radiology workplace of the future together. Thank you.
Hi, can you hear me now?
Yes.
Okay, you can. Great. Okay. And can you see my slides?
Yes.
Okay, terrific. We're in business. So thank you very much, Dr. Bencardino, for inviting us all to speak. I really appreciate, I'll say just like working with Lori on this issue has been some of the most professionally satisfying aspects of my career in the past 5-ish years. And Amanda, I'm so glad to finally meet you through this because it's amazing. We're in the same specialty. I know we're in different subspecialties, but this has been going on parallel, and to hear about your journey is fascinating. And we need to just, we're stronger together in numbers, and so going forth we can combine. So I'm gonna try to. I actually think there's value in hearing some of this repetitive, because it's not something that's like a one and done action. And it's interesting to hear what was helpful in neuro-IR, as well as general diagnostic radiology. And of course, we have our radiation oncology colleagues to consider as well. So I'm required to disclose that I'm editor-in-chief of clinical imaging. As mentioned earlier by Dr. Bencardino, we're having this on UNICEF's birthday. And so I wanted to put it, this topic of paid family medical leave in the context of UNICEF's definition of gender equity. And I like this because it includes at the end that I've highlighted in pink, that gender equity is about the fair and just treatment of both sexes that takes into account the different needs of men and women, cultural barriers, and past discrimination of the specific group. And, to what Lori was ending with, this is not just a women's issue. This is an issue that affects all genders. And there has been a lot of past discrimination, and we are trying to use, to circle back to what Amanda's saying, maybe negative energy to be the change of the future. So in terms of my why, my passion for paid family medical leave started when I was a third-year radiology resident at Cornell. I was really thrilled to be, pregnant with our first baby. Here's a picture of me, like towards the end of the pregnancy, at my first ACR meeting in 2008, outside the hotel that I was always used to be at. And when I found out I was having this baby, I went to our vice chair of education. And in the first conversation, I was just told, well, at our institution, no one ever takes more than 6 leaves. And I was so shocked, I didn't even know what to say. So I went back and I did some research and went back to him with some information about what the ACGME I said at the time, which was that it's just per institutions. That didn't help me there. And also what the ABR said, that you were allowed to take up to 8 weeks leave of absence, but it was at the discretion of the program director. So again, a very individual basis. But I wasn't a science major undergrad. I had studied a program called Ethics, Politics, and Economics. And so I went back to federal law and, of course, found the 1993 FMLA legislation, which was signed into effect by President Clinton, protecting employees who've been at their job for a year and work at the institutions institutions of at least 50 people, to have 12 weeks of unpaid family medical leave. And this was like radical at the time. This is 93, unpaid. Think how far we are from 93, and we're still not with a federal law for paid family medical leave, I think, to Amanda's point earlier. So, and the opening, Dr. Bencardino slides in the opening, comparing where the United States is with the rest of the world. So at the time, I was a resident, and I knew, I figured if I was fighting this battle for sufficient paid family medical leave, then others were too. And whereas I couldn't do much as a resident, and given our hierarchical, the way hierarchy is in medicine, at that time, I was pretty clear that this was going to be a career passion of mine, and I've been working on it ever since. And that child was at RSNA just recently last week, looking at colleges. So it's been like, it's been a long journey, and we can see it's still ongoing. So back in 2008, when this journey began, and as I finished up residency and became an attending, one thing that did change was at the federal level. I wasn't aware of it at the time. In 2010, right at the end of my training, there was a Mayo Clinic case that went all the way up to the U.S. Supreme Court, which established at the federal level that residents are considered employees, which means that they are therefore eligible for FMLA. So there was a discussion of whether residents are students versus employees. This was really critical for our future policy writing, because we had at the federal level established that residents are employees and thus eligible for FMLA. So some of the other things that were going on in the background during this time were in 2013, the ACR Commission for Women and Diversity was established. You see the inaugural chair, Kaja Makora, who's been very involved in supporting in all of this, and Dr. Ellen Bogan, who was the chair of the ACR at the time. And so I became part of this commission the following year, and a liaison to the Human Resources Commission as well. And so we began by, interesting to see, similar to Amanda, starting by publishing an opinion piece, because that's all it was at the time, was our opinion. And this is the first editorial on the topic, JACR, back in 2015, so almost 10 years ago now. And this was like controversial. The FMLA should be applicable to all radiologists and radiation oncologists. And I remember very clearly getting on the phone with everyone on the ACR Commission for Women and ACR HR Commission, and having a vote whether like all the members were going to support this, and if yes, we're going to go ahead and publication. We had to have the ACR legal counsel, Bill Shields, review it just to make sure that it was okay. It was printed, and it says what the title states, that the FMLA should be applicable to all of us. That was a good beginning point, because it enabled us to make the case that we really needed baseline data to assess where we were before we could make a path for where we wanted to go. And this led to the inclusion in the ACR annual workforce survey for the first time in the 2016 iteration of 2 questions related to FMLA. And again, this was I didn't understand beforehand that being part of the Human Resources Commission was going to be so vital to this, but FMLA and leave, this all takes place within HR. And so very, very important to be able to work together with these areas. And so we published this data assessing the utilization of FMLA and radiology practices in 2016 in this article in JACR. So this is the following year after the opinion piece. And what we found was that most radiologists who took FMLA were to care for a newborn or adopt a child, 49%, followed by a personal serious health issue, 42%, or to care for an immediate family member, 8%, with a serious medical condition. So with this data, it really became evident that, contrary to popular belief, FMLA is not just, as we've been saying, women's issue, because both genders need absences for work for FMLA sanctioned reasons. And so obviously these were all like really big developments, but remember that none of this, we're not talking about paid at all. And so the next step was to try to be advocating for paid family medical leave. And Kaja Makora invited me to write this opinion piece for JACR, which first appeared online in 2018, where I was making the business case for paid family medical leave. And I'm just looking at the interest in time. I'll just say, based on this paper and other conversations behind the scenes, some of which I was and some of which I was not privy to, what followed was that the Society of Chairs of Academic Radiology Departments, thanks to Dr. Sherry Cannon, passed a policy stating, and they published this as a letter to the editor in the JACR, that the Society of Chairs of Academic Radiology Departments, as stated in our bylaws, advance the art and science of radiology, and that SCARD members support the AAWR and pledge to strive for departmental, institutional, and organizational change that provides 12 weeks of paid parental leave for eligible faculty members of all genders. So this is the first time paid appeared in any policy, although it was only parental leave and did not include family leave. And in the same JACR issue, so what also happened was that the ABR announced that it was changing its leave policy, and that the policy change would allow up to a 4-month leave of absence in addition to standard vacation and meeting times during the first 3 years of radiology residency. And with this, we were able to finally, this is when Lori and I finally got to work together and drafting a policy statement for the APDR for program directors to consider in support of 12 weeks of family medical leave. Again, this is all unpaid. And Lori was the absolute champion and brought this all the way through the APDR. And it was because of this, the policy statement passed by the APDR in support of 12 weeks unpaid family medical leave, that we were able then to go ahead and ask the ACR to draft a policy for the ACR with all these supporting organizations, SCARD, APDR, ABR, all unpaid. But then the next step was to ask to try to get a resolution passed by the ACR for paid family medical leave. What happened was we submitted that for consideration of ultimately in January of 2020, but then COVID hit, and given all the financial challenges radiology was having, we pulled the resolution at that time, and we're sort of waiting to see what was going to happen next. And then what happened the following year was in response to the ABMS requiring all medical specialties to have a clear and transparent leave policy. The ABR, the American Board of Radiology, suggested that they were going to just issue 6 weeks of leave. And when this came out on a Tuesday, by the end of that day, many of the people on this article, led by Kirti Magudia, myself, Lori, and a bunch of other people who have been mentioned, were working to write this article in support of 12 weeks of leave. This was published in record time 3 weeks later in Radiology as an opinion piece, and it was the basis for us arguing. Here's the article. So again, this article recommended that the ABR leave policy allow a resident who's in good standing to take 12 weeks of family medical leave during residency, in addition to 4 weeks of vacation per year, to sit for the core qualifying examinations on time and to graduate without extension of training. So again, excuse me, just to be clear, nothing about paid at this point, but this was the basis, and it's still a very highly cited article, which was supported by the 12 national organizations and society you see here. And then in the following month at the ACR, and then we were able to amend some resolutions that were in progress to get the ACR to support 12 weeks of family medical leave. Again, all unpaid. And it was finally the following year in 2022 that, as Lori showed, that our resolution was passed, resolving that practices, departments, and training programs strive to provide 12 weeks of paid family medical leave in a 12-month period. And that's where we are right now. And from this, we were able to take the verbiage from our ACR past resolution. Meredith Englander took it up to the level of the American Medical Association and is working so we can try to get this beyond just our specialty of radiology to all medical specialties. And a summary of this and more is on our beautiful website. And I'm like the second where I keep showing it, but like to see this, and Lori brought this to fruition, is just a summary of years and years of work by so many people, and to have this as an accessible resource for going forward is just a huge win. So I think our next action, you got to have policies before you can have implementation policies, but it's not clear to me how well these policies are being implemented. Again, it's a first step because now people don't have to reinvent the wheel, and they can say, well, this is the policy, and like, how are we going to make it happen? So back to my why, I hope that residents and going forward, do not have to reinvent the wheel or take 15 years to achieve what we have. And we just need to be, I think, in terms of next actions, thinking about how we can better implement our policies. So I'm going to stop there.
Thank you so much. So now it's time to open the session for discussion. I don't see any questions yet in the question and answer chat, but I like to make a comment. I waited until I was done with training to have babies. By the time I got pregnant of my first, I was 35 years old. And so I was given a label of being older than all women having, being pregnant. I don't want to use the diagnosis because it gives me the grips, but and so that I had to have, a set of added tests. I had an amniocentesis done and so on because of this. We know that the rate of infertility in women physicians is 1 in 4 women physicians have to face the fact of being having trouble conceiving their babies. And I strongly believe that all the efforts that the panelists are doing and continue to do are going to greatly impact not just the physical, but also the emotional well-being of women. Not, of course, the impact on families. And not having to go through the pain of, dealing with infertility treatment. So I just like to, hear a little bit of your perspective on this and how it affects, women radiologists.
Are you asking anybody that's on the?
Yeah, anyone.
Okay. All right. I would just start, I would just say my goal when I had our daughter Amanda as a first-year resident was I almost quit that year. That's how bad it was. Unfortunately, I had a chair that worked with me and I stayed on, and I'm so happy I did. However, it was so hard to do that. And because that's when we took call 6 months, it was crazy. But I really am encouraged to see we're starting to move the needle. It needs to need to keep the momentum going, and that's our goal.
Mm-hmm.
Can you see my slides?
Yes.
Okay. I mean, to Lori's point and to what I was talking about earlier, what is my goal for the next step? We have these policies, but my question to all of you on the call and really beyond is I'm wondering whether your practice or department has a written accessible policy consistent with the ACR resolution that practices, departments, and training programs strive to provide 12 weeks of paid family medical leave. So either people can put it in the chat or just open it up to conversation. Does your practice or department have this? Both written accessible, or it's written, or you just don't know, or you don't. So the bottom first, we got to get it from the ACR level, trickle down to practices and departments, and I think. Whereas a lot of the work to move the needle on these issues has been in academia. To Lori's point, most of the ACR members are actually private practice radiologists. And so I think this is where there can be a convergence of academics and private practice in terms of potentially moving forward with implementing policy. And also because this is such a tight job market for radiologists, I'm hoping that, capitalism is going to shake everything out. There's only a certain number of radiologists to fill these jobs, and for jobs to be competitive, I'm hoping that they're gonna, be moved to have policies consistent with the ACR or even be more generous.
So I just put a box in the Q&A for people to go in and say A, B, C, or D, so we get some data about what is happening in your departments, and if you don't know, there is numeral D that you can use. We have new books. Mm-hmm.
And we have a couple people with their hands up too. So
I can't see both my questions and the chat and the people, so please go ahead, Jenny, and go for it. Someone moderate.
I am not seeing the people.
No, Nolan has his hand up, and then Judy. I think Nolan first, according to
I see that. Yeah,
okay.
I see that.
Okay.
So Nolan, go ahead, please.
No, first of all, thank you for all of the speakers for this wonderful panel, and my goodness, the incredible work you've done over the years. And then my why to be an ally in this area. My sister, 2 years younger, was an intern and had to use 2 weeks of vacation and then was back pushing patients in wheelchairs, and she said she felt like her insides were going to fall out. And her colleagues at the time had no empathy for her and thought, oh, you're back from vacation, now you can get back and do your job. And it was horrible. And so we've made progress, but we need to make more progress. So I'm happy to collaborate and support you all.
Great.
Thank you,
Thank
Nolan.
Thank you.
So
Thank you for
important.
sharing.
Yeah, so important.
Yeah, and now Dr. E.
Yeah, I'd like to echo what Nolan said, which is thank you to the panel for doing this. Is such an important topic. Thank you to Dr. Bencardino for the work that she's put into organizing this on behalf of the New York State Radiology Society. And my comments are that I wear a lot of different roles and hats here. As a chair of a large department, I am heavily involved society-wise in diversity and inclusion, and being involved in SCARD as well, as being president-elect, and then probably most importantly as a mom. I appreciate all the efforts that have been put into this, and I wasn't even aware of the extent of work that has gone into this, but it's astounding. So congratulations to all of you who've put in so much work. My comments are that I feel that in looking at what's been done at the national level has been amazing, and what you've gotten published, but what in reality is happening is not so clear. And I feel that it's much more at an institutional level, whether there is support, and the extent of the support. How deep is that support? We can all put things in writing and, but when it comes down to, our institutions actually following policy, because when you look at what the policy, it is strive to provide. It's not a mandate, right? So there's wiggle room. And my concern is that when you leave wiggle room, that, there is less bite into following.
Mhm.
And I would open it up to the panel to provide some comments as to how we can provide a little bit more, I guess, consequence when such policies are not followed rigorously. It's tough.
Elizabeth, would you like to answer that?
Anybody on the panel, or Jenny, if you would like to?
Yes. I'm wondering, since Elizabeth has worked so much on policy, and if she'd like to answer that question.
I mean, you cannot imagine how many radiologists and how many rounds and how many days, months, weeks it went to arrive at the little 6-letter word strive. Whenever I'm reading this out, I'm saying strive, because those of us who were involved in it know how long it took to just get that word. That was the only word that we could get unanimous sort of consensus in moving forward with. Because every department in practice is different, and the ACR understandably felt like it could not mandate specifically. So the word strive was what was agreed upon and ultimately passed. So I hear you, it's not a mandate, but hopefully it's the first step, and it's also something that that people interviewing for practices and departments and or residents can at least turn to in service of, like, well, our main governing body says that it's like, this is what we're supposed to strive for, so this is what we should be heading to. Yeah, it's really hard.
Yeah, no, I hear that, and I totally understand it. Again, putting on my different hats, that's what I key in on. And I would question whether, after the resolution was passed, whether there is now effort to look at when the resolution passed and to, some interval of seeing the effect of the past resolution.
I can just speak to that a little bit.
Yeah.
So the survey that was, that recently conducted by, so the ACR was involved with that, as well as the AAWR and the Society for Women in Radiation Oncology. I think that it was the advocacy committee for the AAWR came up with the idea for that survey, and I think that's a first step in trying to see what's happening now. But we're definitely open to other ways to assess that, because knowing where we are now will help determine what we need to do to get, move this further. So that's the only that I am. I don't know if anybody else is aware of data. We were also, one thing that the AAWR would like to do is reach out to get some story. We'd like to put some stories on our website of like hot places and practices and departments that have been able to operationalize this, implement it, and how they did it as sort of examples of, success stories. And that's one of our next steps too, is to reach out to people and start to try to identify practices and departments that are doing this well. So if any of you have a success story that you can share with us, you can, I can be the point person on that, but we are looking for that too, just to help people envision how they can do this.
Lori, we should do, so as editor-in-chief of clinical imaging, I'll say I would love an article that's moving from policy to practice. That's really what we're talking about here, right? We've got the policy, the best policy we possibly can at this point. Who, how, the 5 W's and H about implementation. So I'd like to publish that.
It'd be great if there's any way that we can help from the SCARD side to help get department chairs to provide data or provide help. Let me know.
It seems like there's so many programs in New York State, and New York State actually has a law that we could be the first, but collaborate and figure out what New York State's doing and just saying.
I know. Oh, sorry. I thought you were. Are you done? Okay. The other thing is, I would really like to, the word has changed from maternity leave to parental leave, and I would really like to make this, as much as I am an absolute female advocate and, I'm very involved in a lot of women's groups. I think in this area, one of the ways that might help is to make it less of a woman's issue.
Yes.
And make it a person issue.
Yes.
And I think, with how families are just changing now, it is a person issue. And I think if we have more, and thank you so much for joining, Nolan, if we have more support from everyone, and it's not just women against men, that might really help. As much as you feel the pain actual of childbirth, but I think that really involving everyone might be helpful.
100% agree, Amanda. And I think, putting in the lens of well-being for all people, all physicians, and physician well-being, we have to take care of ourselves so we can take care of our patients is a hard thing to argue against. So.
Well, we come to an end. It's almost 1 p.m. already, and I cannot express my gratitude enough to our panelists. Thank you for really magnificent work that you've done, not only today presenting, but all the work that you put into advancing paid parental leave in the United States for radiologists and setting an example for other medical specialties. Thank you so much.
Thank you. And Amanda, please can we be in touch? It's so good to meet you through this. Let's not let this drop.
Yeah,
Yes.
Likewise. Nice
Okay.
to meet you all.
And I want to
Bye-bye.
thank Judy too.
Yes.
I think we should reach out to SCARD.
Yes.
Okay,
good plan.
definitely.
Thank you.
Now she's the president.
Yeah.
Yes.
Thank you.